My name is David Sallman from Moffitt Cancer Center in Tampa, Florida. I present a abstract on the long-term follow-up of eprinetapop, or APR-246, for P53 mutant MDS and oligoblastic AML patients. It's actually an international collaboration between the US MDS Research Consortium and the GFM. Essentially, there were two parallel phase 2 studies recently published in the JCO, and we put the total cohort together for patients up to 30% blast, which actually represented 100 patients, the largest prospective P53 cohort undergoing clinical trial. As far as the overall response rate, the true complete remission rate was 43%, and the median duration of those responses was close to a year. What was really important was that patients that had biallelic or complex karyotype at baseline, which represents sort of the poorest of the poor P53 mutant patients, had the best complete remission rate. And then we really started to look at how does the impact of the quality of the response, meaning complete remission, or the clearance of the P53 mutation to less than 5%, how does that impact outcomes? And overall, patients that achieved that had improved overall survival. But what's somewhat more remarkable is when we look at patients that ultimately went to transplant, the group that had CR or cleared their P53 mutation actually had a median overall survival that was not met. It's a small subset, but it's really one of the first instances where we can clearly see an improvement in outcomes in P53 mutant patients going to transplant. There's actually a couple other abstracts at this Congress, one focusing on the same agent with azacitidine as maintenance, and that also seems to improve it. So maybe we could have this concept of total therapy where patients get treatment pre and post and ultimately lead to improved outcomes and potentially cure for a subset of these patients.